Thoracic outlet syndrome is a syndrome in which there is compression on the neurovascular bundle in the thoracic outlet, causing a disturbance in nerve or vascular function in the upper extremity. There are three borders of the thoracic outlet. The inferior border are your ribs, the superior border is the clavicle, and the posterior border is made up of the scalene and pec minor muscles. The neurovascular bundle that runs through this area includes the subclavian artery, which comes off of the aortic arch, the subclavian vein, and the brachial plexus between the anterior and middle scalene muscles. There are three potential areas of compression, including the interscalene triangle, the costoclavicular triangle, and the subcoracoid space. There are two general types of thoracic outlet, neurogenic and vascular. Within neurogenic, there are two subtypes, a true or nonspecific. The nonspecific is the most common thoracic outlet syndrome in approximately 85% of all cases. This is occurring somewhere within the thoracic outlet. The true neurogenic occurs in 1 in 1 million people. This is usually due to a cervical rib or fibrous band constriction to the first rib, which compresses the lower trunk of the brachial plexus, resulting in paresthesias. The second type of thoracic outlet syndrome is vascular. It occurs in approximately 5 to 10% of all cases of thoracic outlet syndrome due to an extracervical rib. That extracervical rib is actually a misnomer. It is not an extra rib. It is more of an extension off of the cervical vertebrae. This cervical rib then compresses either the subclavian artery or the subclavian vein, or potentially both. Several mechanisms of injuries occur. First of all, it can be due to a posture. When a person has a thoracic kyphosis, this shortens the anterior muscles and weakens the scapular retractors, which may contribute to the problem. Scapular dyskinesis may contribute, as well as military position. In the military position, the scapula is retracted and depressed. You will see this oftentimes in people who are carrying a heavy object like a backpack. There may also be structural causes. It may be due to a malunion clavicle fracture. There may be a fibrous band fusing the scalene anterior and middle muscles together, or as I mentioned previously, that cervical rib, which occurs in about 0.5% of the population. You also may see this syndrome occur in individuals with scalene muscle hypertrophy, such as wrestlers, weightlifters, or people who are involved with crew. Signs and symptoms include upper extremity weakness with overhead movement or shoulder depression, this being the primary complaint. You may have neurological concerns, especially with the ulnar nerve. The person will complain of paresthesia and radiating pain throughout the upper extremity when the arm is abducted above 90 degrees. Vascular signs may appear depending on what is being occluded. If it is the subclavian artery, this will present with coldness or cyanosis of the nail bed or pallor of the arm. If it's the subclavian vein, the person will complain of stiffness and venous engorgement of the upper extremity. Range of motion will present with shoulder abduction of 90 degrees or above, or shoulder depression inducing symptoms and a reduced range of motion. There are several special tests that can be used, although a lot of them will cause a high number of false positives. The first is the Adson's test. The subject is going to sit or stand with the examiner behind the person with the fingers over the radial artery. You will then externally rotate and extend the patient's test arm while palpating that radial pulse. The subject then extends and rotates the neck toward the test arm and takes a deep breath. A positive finding will be a diminished or absent radial pulse, which is indicative of thoracic outlet syndrome secondary to compression of the subclavian artery by the scalene muscles. The second test is the Allen's test. The Allen's test is performed with the examiner behind the patient again. However, this time the test shoulder is in 90 degrees of abduction and external rotation, with the elbow in 90 degrees of flexion. Again, the examiner is going to place their fingers over the radial artery distally. The subject is then instructed to rotate the neck away from the test arm while the examiner palpates the radial pulse. We are again looking for a diminished or absent radial pulse. This assesses the subclavian artery in the interscalene triangle and pec minor. The Ruse test is also called the elevated arm stress test. The person is simply going to place both shoulders in 90 degrees of abduction and external rotation, and the elbows in 90 degrees of flexion. The patient rapidly opens and closes the hands for 3 minutes. The positive finding is the inability to maintain this test position and or having diminished motor function or loss of sensation in the upper extremity. The final test is the military brace position. Standing in anatomical position, the examiner stands behind the patient and unilaterally assesses the radial pulse. The subject's arm is then passively extended and abducted to 30 degrees by the examiner, while the patient simultaneously hyperextends the head and neck. This test will assess the subclavian artery in the corticoclavicular space. Neurovascularly, you will want to perform an ulnar nerve assessment. Diagnosis-wise, there are several different tests that can be performed. An X-ray may be used to rule out a cervical rib and assess the impact of a clavicle fracture. An MRI may be used to rule out nerve or cord compression from cervical joint degeneration or herniated disc. A Doppler ultrasound will look for vascular compression. Phlebography will look for the subclavian vein being occluded. An arteriography will look at the subclavian artery. And then electrodiagnostic testing, such as an EMG or nerve conduction test, might be performed. Treatment is going to be cause-specific. Generally, some type of scapular stabilization will be performed. Surgery may also occur to release or remove the compressing structure.